So since it's a few minutes after 4, we will go ahead and get started with Coffee with a Clinician. Coffee with a Clinician is a little program of Alaska Behavioral Health where we're just giving people a chance to talk about kind of common mental health concerns with one of our clinicians. So today I'm going to ask our two folks that we have online to introduce themselves. Caitlin, why don't you go ahead?
Hi, I'm Caitlin Gobb. I'm a marketing and communications intern at Alaska Behavioral Health currently and working on my bachelor's in journalism and public communications at UAA.
Awesome. We're so
Oh,
glad to
hi.
have you. Go ahead, Joshua.
Yeah. Hi, I'm Joshua Arvidson. I'm the Chief Operating Officer of Alaska Behavioral Health, and I was the co-founder of the Alaska Child Trauma Center here 20 years ago. And I'm also the director of the Rural Child Trauma Center for the National Child Traumatic Stress Network. So good to see you.
Cool. And so for today's format, Caitlin is just kind of going to lead a conversation with Joshua. And yeah, I definitely invite everyone to hop in and ask questions. If you are watching on Facebook Live, I am monitoring over there too. So please go ahead and comment on the video with any questions that you have. And we'll try to get those over here to the guests today. And so with that, I'm going to turn off my camera and video and leave it to you two.
Cool. So, do we want to go through your slides first, or kind of how do we want to structure this?
Yeah, I can jump into kind of walking through the slides. I think what would probably be helpful first is talk a little bit about the roadmap model, kind of why I developed it, and then kind of go through it and talk a little bit about how it's being used today. So what I'm going to present is a model for thinking about how traumatic stress impacts the brain and our responses to traumatic stress. And I originally developed it out of my clinical practice working with children, adults, and then also parents of children who experience traumatic events. And I think one of the things that was really interesting is there's a lot of emerging neuroscience around traumatic stress. But the key is to make this neuroscience really accessible and relevant to people who've experienced traumatic stress, to make it relevant for anyone who's not a neuroscientist or a clinical psychologist or physician to be able to get our heads around. And a big part of that is I really do believe in psychoeducation. So I think the more you know about what you're experiencing, particularly as someone who experiences, for example, PTSD, the better you're going to be able to recover and be resilient. So we developed it really with that kind of intention. It was originally like a scribble on pieces of paper that I would use when I was meeting with clients here at this table behind me. And then over the years, the model kind of took off, and so we started incorporating it into Trauma 101. And now it's used by trainers in several different evidence-based treatments around the country as a way of explaining traumatic stress in a way that's true to the neuroscience, but also accessible to everyone. So that's kind of a little bit about why we developed it and where it comes from. And so we'll kind of walk through it real quick and then go from there. So I'm going to share my screen. Okay. All right, so let's do this. Let's go from beginning here. Okay, so when we think about how the brain is responding in an acutely stressful situation, now this is important. So I'm not talking about post-traumatic stress yet. We're just talking about how your brain responds when you are in a potentially life-threatening in a situation, right? So we call that traumatic stress, but not necessarily post-traumatic stress yet. So when you are in an acutely stressful situation, we see things happen in the brain, and we can look at this after the fact with fMRI by asking people to recall acutely stressful situations and looking at what happens in the brain when they're actually thinking about what they went through, because they're really similar. And what we see And I'll use the hand model of the brain, which comes from Dan Siegel here. But if you take your hand and you tuck your thumb into your fist there and look at it from this side, it kind of looks like a brain, like the brain we've got up here. And what we see happening is when you're in a really life-threatening situation, the activity in your brain changes. Okay. And example I like to use here in Alaska is if you were fishing along one of our rivers, which is a popular activity in the summer, and a grizzly bear came out of the bushes behind you, your body would respond really quickly, right? And we've all been in those kind of scary situations where you feel like your heart starts pumping and you feel it in your gut, this like sense of fear or dread, and your rate of respiration goes up, your blood pressure goes up, your sensory perception, narrows in and really focuses on the potential threat. All these things are happening. And at the same time, your body is getting ready to mobilize your resources to respond to this dangerous event. And for those of you who aren't Alaskans, I know you think you should run, but you don't want to run from a bear because it just gets them to chase you and they're faster than you. So you kind of have to like think about what you're doing, but your body's getting ready to respond. We also see a response happening in your brain too. So one of the things that's really interesting is when you're in an acutely stressful situation or you're recalling one, like in an fMRI, we see decreased activity in this neocortex, kind of the thinking center in the brain. And we see increased activity in the alarm system of the brain, particularly housed in the limbic system, the amygdala. Amygdala is often known as the fear center of the brain, although it's also activated with other strong emotions. And so sometimes people wonder, why would I have this big change in the way my brain is responding, my brain is functioning when I'm in an acutely stressful situation or dangerous situation? I would say it's just the same as your body. Your brain is getting ready to mobilize a response. So we see this shift. And when you think about, okay, what is that about? Why is that happening? If it happens kind of everywhere, so it happens across cultures, it happens across populations, men, women, young, old, all different backgrounds. Then it's got to be biology. And I really do believe if it's in biology, it has a reason. It's been selected for over time. And I think the reason is to keep us alive, right, in a potentially dangerous world. So I'll go to this next slide. So what I just showed you is like a very oversimplification of like hundreds and hundreds of brain imaging studies. But then how do we translate that into a model that makes sense, that makes more sense for how we actually function and what we do in a stressful situation? So this kind of roadmap here, I kind of laid out, and you could add steps, you could take some away, but this is a basic kind of description of what your brain might be doing under sort of normal conditions or typical conditions. We like to say typical instead of normal because the word of normal, abnormal, gets into that whole like, people who experience traumatic stress often carry a lot of shame and stigma. And what we always say is your brain is not broken. Your brain is doing what it was designed to do. It's designed to keep you alive. That's really important. So your brain is maybe just doing what it was designed to do, maybe too much. Maybe it's doing it when you're trying to sleep or you're trying to work and your brain is on hyper alert mode. But that doesn't mean your brain is broken or abnormal. Your brain is just doing what it's designed to do, which is keep you alive. We got to work on turning that alarm system down, but that alarm system really serves a purpose. So under normal conditions, you might observe things in the environment that comes in as input, you interpret it, you process it, you evaluate different options, you plan, and then you act. And you could put some extra steps in here, you could take some of these away, but this would be kind of like, a way you might decide where you're going to go to college, or what you're going to make for dinner, or, how you're going to change a light bulb in your truck. I mean, there's lots of, so you just day to day, this model really works really well. Your brain kind of goes through this process step by step. But in as much as this process works for us in most situations, it doesn't work when we have to respond to something really dangerous really quickly. And a lot of dangerous things are really quick. So, and even something that maybe you wouldn't think of as like a traumatic stress situation because it resolved fine. But even this morning, I was driving into work on the Glen Highway here in Alaska, and someone, I think they were texting on their phone, but because their head was down and they started to drift into my lane. Okay. And we're going 65 miles an hour speed limit, but 65 miles an hour down the Glen Highway, and there's a truck drifting into my lane. And I had to respond like that, right? So I tapped the brakes, and then they figured out what they were doing and drifted back. If I think about the amount of time that I had to decide to tap my brakes was like less than a second, right? I mean, my response time was more than a second, but like my brain made that decision really, really quickly. So it couldn't do this process that we're looking at over here. It couldn't say, oh, there's a truck drifting into my lane. They're violating the traffic laws. Shame on them for texting and driving. Therefore, I have three options. I could swerve, I could accelerate, I could hit the brakes. What are the possible, ramifications of those three options? If my brain had gone through that whole process, too late. We're now in an accident. So my brain had to do a shortcut. And I think it's helpful to think about just like a normal thing that our brains do all the time. If you were, I don't know, in a gym class in your high school right now, and a basketball came flying towards your head, you're not going to go, there's a round spherical object headed towards my cranium. This could be unpleasant based on prior experiences. I don't want to get hit in the head. So I can catch it, I can block it, or I can dodge it. What's the pluses and minuses of each of those three options? No way. The basketball's already smacked you in the face if you do that. So you're just going to do what, maybe, I don't know, if you're a basketball player, maybe you catch it, your volleyball player, maybe you'll block it. I don't know, but you're going to do something really quick, right? Boom, right, really quick. And that's normal. And our brain is built to do that. It helps us survive. So we call that the shortcut. And so this slide then says, okay, observe, you're observing, truck swerving into my lane, react. Basketball coming towards my head, react. Grizzly bear in the bushes of a river in Alaska, react, right? And it's going to do a shortcut. And, people talk about fight, flight, freeze. So you have these those are just behavioral responses driven by this, but straight to action, right? Tap the brakes, catch the basketball, Um, and we call that the express route. And this is normal. You got to have it. You wouldn't be able to operate in life as a human being without having this shortcut route. And all those extra steps, evaluate options, pluses and minuses. You just don't have time when there's a basketball coming towards your head or a truck swerving into your lane. And we've known this way before we had brain imaging studies, right? Because how do we train firefighters, Marines, emergency room nurses, right? Repetition, 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 because we know, yeah, that emergency room nurse, he or she totally understands how the circulatory system works, but when they've got to put an IV in and they got to do it right the first time, and there's all sorts of stuff going on, they have to practice that over and over because their brain is in express mode right now. It's just boom, boom. So in some ways, it's not fight, flying, and freezing. It's relying on its training, but it's a repetitious act that's been practiced over and over again. And so we've known this for a long time. Before we could see it in the brain, we knew that this was how the brain functioned in these stressful situations. So all this is fine and normal. This is part of what makes us human beings and able to survive in a dangerous world. Here's the problem. What happens? What's post-traumatic stress? So this is not post-traumatic stress. This is just your brain doing what it does, okay? But what happens when and we think of it as a fire alarm. It's like the little red box with the white handle, you probably had in your high school or elementary school or, public buildings have. It's a fire alarm. What happens when that fire alarm has been pulled so hard or so many times that it's going off? It's almost, I think of it like you pulled the handle so hard, the handle hasn't snapped back into place. It's sort of hanging off the wall at a 45-degree angle, and all it takes is, and that alarm goes off. That's what we think is happening when people are having recurring nightmares and re-experiencing and flashbacks, or they're on constant alert mode, or, they were in combat stress and they hear like a bang of a door down the hallway and they're like diving under their desk because their alarm system is staying on, or it's easily triggered all the time. And what is going on in the brain that's causing that? Obviously, we know what the original cause was. They had some life-threatening event that cranked their alarm system up. But we think what's happening is that this alarm system express route that's supposed to be like okay, I just need to use it when someone's swerving into my lane in traffic or a basketball coming towards my head. This alarm system route is now becoming the primary route. And that observe, what does that really mean? Is that really dangerous? That longer cognitive process is now becoming the less used side path. And we get really concerned. This is part of why we think the more you're exposed to chronic stressors, the higher your chances of developing PTSD, or the more severe the stressor is, because that alarm system in some way is being kind of wired up as the primary route. And again, this is really important. Sorry, I'm going on and on here, but it's a really important message. This is still normal. This is your brain just doing what it's designed to do. If you're in combat, yeah, your alarm system's going to be on. And it's going to be on all the time. And it's going to be hard to sleep. And it's going to be hard to do other things. It's going to be on that all the time because you're in combat and people are trying to kill you. So you need it. Okay. If you're in a dangerous situation, if you're in a domestic violence situation, your alarm system's going to be on all the time because it's trying to keep you alive. So I think it's really, really important to normalize this. And even when someone experiences PTSD, I still say it's still a normal response. All that's happened is your brain has experienced a trauma that's so severe, or it's experienced it so many times, that your brain is a learning brain. And it said, there's a lot of swerving trucks in this world. There's a lot of basketballs headed towards my head. There's a lot of grizzly bears. There's a lot of danger. And so my brain, just like, is going to learn, just like it learns anything else. And it's going to start to choose this alarm system as a default mechanism. And that's what we think PTSD is. I mean, there's a lot more to it, but at a simple level, that's what we think it is. So that's the roadmap model, kind of really simplified. I've presented this to neuroscientists who do nothing else than study PTSD, and they're like, yeah, this is accurate. I mean, there's a lot more detail, but this is what we think happens. So that's kind of it in a nutshell. So I'll kind of stop there and see if you have questions or responses.
Yeah, so I was first thing that came to my head was is it more of a habituation of being exposed to repeated traumatic events, or events where you have to react quickly, or could a single event trigger the same response?
Really good question. It's both. Yeah, so it's really interesting. I'll try not to get into all the debates around how the PTSD diagnosis has changed and evolved over the years, but there's been a lot of debate. It can be both. You can develop PTSD after an exposure to one acutely stressful event. We also know that exposure to stress has a cumulative effect, and not just a cumulative effect in terms of chronic stress is bad for you, and it is bad for you. But it also, we know that more trauma you're exposed to, the more likely you are to develop post-traumatic stress disorder, which, this is just one part of the full kind of post-traumatic stress disorder, but it is part of what we think is biologically driving it. So it can be either. And there's been a lot of debate in the field about that. Because when we first developed the PTSD diagnosis, and this was before my time, but when the PTSD diagnosis was first developed, there was a lot of focus, for example, on combat stress. Combat stress is acute, but it's also chronic. In most combat situations, there's chronic exposure to stress. But there's been a lot of research that shows that PTSD can be elicited by a single event, something like a sexual assault or witnessing violence. And there also can be a cumulative impact over time. And one of the things that we know can happen is chronic exposure to something that wouldn't maybe have necessarily caused PTSD if someone had just experienced it once, but they experienced it 15, 20 times. We can see the development of PTSD due to chronic exposure. This model actually helps me understand that a lot, because I just think of it as this really terrible thing happened, and so the express route became the default route because you almost died, right? And your brain is adaptive, and if you almost died, it's gonna pick the route that kept you alive. Or it could be, we use the express route over and over again because we keep experiencing chronic stressors, and so it becomes prioritized that way. It could be either way.
Yeah. So kind of you still can physically use the other, the processing what's happening and everything, but it becomes well, this is just what we do all the time. So, yeah.
Yeah, that's a really interesting observation. How much access do you still have to the other path, other method? And this is where it gets really complicated. And I'll just speak from my experience now as a clinician, not necessarily summarizing the research. My experience as a clinician has been that in almost all circumstances, people retain some ability to use that other route, the thinking things through, evaluating your options, what I call the non-reactive route, right? The planful strategic route, but it becomes harder and harder. That's one thing. The second thing, and this is where your question gets really critical, is I would argue that once you get far enough, and the illustration really shows this, like there's a turning point between the two routes and they get farther apart as they go. So the farther you get down the alarm route, the harder it is to jump to the other route. So that's where we get into thinking about what we do in treatment and what we're trying to do when people experience PTSD is we're actually trying to back up to that moment in time when you saw I'll use a different metaphor because I want to use something that could be either. Could be danger or could just be a routine. And you could go an alarm system route or you could go think things through and consider it again route. And I'll use a very non-Alaska example here because we don't have snakes in Alaska. So I feel good using a snake thing because it's not real for me, okay? But let's say I'm your therapist, Caitlin, and you got bitten by a rattlesnake, okay? And you almost lost your foot. It was terrible. It was traumatic, horrible. I'm scared of snakes. Maybe that's why I live in Alaska, but I'm just thinking about it. Ugh. Okay, so you got bit by a snake and you develop PTSD, which can happen. You can have so to your question, could at one time event you could develop PTSD. So you now, and you've got all kinds of PTSD symptoms. You're not able to sleep at night. You're on alert all the time. You don't want to leave your house. It's not agoraphobia, it's snakeophobia, right? You're afraid of the snake. Okay, so I'm working with you in treatment around that. And one of the things that can happen is you can be out in the world and you can see out of the corner of your eye something coiled up. Like, and let's make it not a snake. Let's make it in real life, it's a garden hose. Okay. You're walking down the sidewalk outside your house and you see a garden hose out of the corner of your eye. So this is a stimuli that, right away your brain may be thinking snake, 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 and then you run back in your house and you don't leave your house for another week. Okay, so that's not the outcome we want. So instead, what we want to be able to do is like you see that coiled thing object to the left out of the corner of your eye. Can we just stop for 1 second, take a look? Okay, that's a garden hose. Now I'm gonna guess, even when your brain is like, that's a garden hose, your heart's still probably beating a little faster, right? I mean, I could even feel it thinking about it, jump up my anxiety a little bit. And so we're going to expect a physiological response. We're not trying to get that to go away. I mean, honestly, I kind of want you to be a little bit afraid of snakes. I want you to like live your life and leave your house, but snakes are bad news. Like getting bit by a rattlesnake, let's try to avoid that. So that alarm system, I'm not trying to make it go away. All I want to do is slow it down just enough so you can take a second look and say, is that a snake or is that a garden hose? If it's a garden hose, let's continue our walk. Yeah, our heart rate jumped up a little bit. And that's an example of what we call exposure in treatment. Exposure. So you were exposed to a stressor that reminded you of the event, but it wasn't the danger itself. And you were able to like take a second look. Okay, just a garden hose. Don't need to panic. Don't need to run away. And I'm going to continue on my walk. And yeah, I would guess your heart rate's a little higher, your blood pressure's a little higher than it was before you saw that garden hose, but you're able to kind of power through it. That's what we're talking about. So when you ask that question, like, what about the other route, do you still have access to it? What I would argue is like that decision point was really around that. Is it a garden hose or is it a snake?
Mhm.
If it's really a snake out of the corner of your eye, yeah, go get out of there, so that's what we tried to do is try to back up to that point at which we call it the threat appraisal system. Once your threat appraisal system says rattlesnake nearby, yeah, alarm system route, we kind of want that. So it's rolling back to that point. And this is really important because we're not trying to turn your alarm system off. There's fires in the world. Fire alarm's a good thing. We just want your fire alarm to have, I call it the fajita setting, right? Someone's cooking fajitas in the kitchen. Doesn't mean the house is burning down. I smell smoke. Oh yeah, they're making fajitas. Check it out. Go on with your day. So yeah, you do have access to the other system. And actually, we don't want either system to stop working. We just want you to have a little more control over which system you're going to use in which situation.
Yeah. So it's kind of rebuilding that threat appraisal system.
Yes, absolutely. Yeah, that's actually
Kinda
really well.
tapping in.
That's exactly how we say it.
Yeah.
Retuning the threat. We call it the threat appraisal system. Yeah, good. Yeah, that's exactly what we call it, because once it is a threat, we're not trying to make you not afraid of rattlesnakes. You should be afraid of rattlesnakes. Is that appraising that threat and letting your brain interpret that threat, and then that alarm system, if that's what you need, that's what you need.
Yeah. Another thing I was curious about, if your traumatic stress happened as a child and you maybe didn't have that established positive or more standard threat appraisal system. And so all you know is that like danger, danger, danger. How do you kind of try to rework that?
So much there. Okay, two
Yeah.
things. We'll start off with. The first one is, yes, part of why we're especially worried about exposure to stress during childhood is just think about it really simply. What are children's brains better at than adult brains? Learning. They're learning machines. If I and my 5-year-old niece both went to France for 2 years, who's speaking better French at the end of the 2 years? Not even close. I'm still just an American who knows some French words. At 5, she's speaking French like she's French after the end of 2 years. And I picked 5 because language acquisition is just off the charts at that age range, right? At the age of 50, terrible language acquisition skills. Terrible. So yeah, that's a specific example of language, but kids' brains are just better at learning. They're able to adapt to the environment more quickly. They wire up. This is why, if you want to be a professional soccer player, you can't learn to do it in your 30s or your 20s. It's not just the physical, it's actually the brain. The brain learns how to be a soccer player better at 6 than it does at 26. It's just the way kids' brains work. So that's the beauty of kids' brains. The challenge is that kids' brains will wire up to stress. In some ways, we think even more quickly than adult brains. Now, the nice thing is we can get kids out of stressful situations and provide them with treatment and assistance. We also see kids recovering really quickly. So the flexibility works in both directions. So that's part of what we're concerned about. The second piece that you kind of put in there, which I think was really interesting, was what about when they maybe don't have a threat appraisal system, there's chronic danger. And part of the element that we're thinking about there is that for children, caregivers, and we use caregivers as opposed to just parents because it's all the, teachers are a role, grandparents, all the big people, as kids would say, are the primary buffers of stress. So the presence of a safe, stable caregiver will buffer stress a lot for a child. It also will help children interpret potential danger in the environment. Sometimes kids are scared of things they don't really need to be scared of. And an adult will say, oh no, that's just a stuffed alligator. It's not a real alligator. Yeah, he's got teeth, but look, he's only this big. It's just, so caregivers will buffer stress for kids a lot. And so that's a big piece too, in terms of helping kids both prevent traumatic stress from really having a huge impact on them, and then recovery. We look at what's the ability of the caregiving system to buffer that stress, because kids really interpret those dangers in the environment through the responses of their caregiver.
Yeah.
Yeah.
That makes sense. Yeah, let's see. So I think to circle back to the roadmap as a whole, kind of, so you mentioned exposure therapy as kind of the main mode of trying to rebuild that. What other kinds of therapy is used to rebuild that?
Yeah, that's a good question. So there are a lot of different evidence-based treatments. My first thing is I always want to go with an evidence-based treatment over just something random, because I really do think when we're helping people recover from difficult events, or people are experiencing, for example, post-traumatic stress disorder, just like if you had a diagnosis of any other physical condition, you would want your physician to be using something that's backed by science and evidence. So we always go to evidence-based treatments. What's really nice, this has changed a lot. I've been in the field for almost 30 years, and evidence-based treatment has really taken off in our field. It's part of why I went into behavioral health in the first place. I could see like behavioral health is really going to apply scientific methods to what we do. There's still a lot of art and relationship, and all the human components are really important. But what you do in a good therapeutic relationship is also important. And we've seen, gone from just a handful of evidence-based treatments to several, and evidence-based treatments that are specific for adults, kids, all different kinds of variations. What I would say about the evidence-based treatments in general is, especially early on, a lot of them were what we call exposure-based treatments. What an exposure-based treatment does, and probably the best way to think about it is think about, and want to be technically correct here. So we think about PTSD, post-traumatic stress disorder, as something more than just another category of anxiety disorder, for example. But some of what we learned about treating anxiety disorders in our field really was applicable to post-traumatic stress disorder. Okay, so that's kind of a technical piece there. And in anxiety disorder treatment, what we learned is that, and this is really important, if we can help you develop some calming and downregulation skills, and really important, some confidence that you can do it, okay? We do that, and then we carefully, deliberately expose, and the term expose kind of throws people off, but basically remember, recall, write out, journal, art, lots of different ways, the event or things that remind you of the event. We call that exposure from anxiety treatment. And if we do that, but pair that with that calming and regulation, we can start to uncouple the stressor from the intense physiological response. And so it's not about making the memory go away. It doesn't go away. In some ways, as a learning human, you don't want your memory of terrible things to totally go away, because it helps you stay safe in the future. Not that it was your fault that it happened. That's really important. That's not what I'm saying. What I'm saying is, I do want your brain to learn, because a learning brain is able to keep you alive. So it's not about getting rid of the memory, but it's about decoupling that intense response from the memory, not from the event, from the memory of the event. See, that's the thing about post-traumatic stress disorder. If you're literally like almost about to step on a rattlesnake, have the alarm system response, okay? I don't want that to go away. I just don't want you to have garden hoses trigger that alarm system response. And so that's what's happening in exposure-based treatment in a nutshell. There's a lot of elements to it. But if you think about it, anxiety, so let's think about something that's not traumatic stress. Let's say you have agoraphobia, and you have a fear of leaving, and you haven't left your apartment in 2 months, okay? And you're terrified. When we think about gradual exposure, what I would probably do in treatment with you is we would start off just drawing a picture of outside, thinking about outside. We'll progress through that. I'm skipping some steps for brevity's sake. Maybe sit next to the window in your house and crack it open, okay? Then maybe sit next to the front door with the door cracked open, just looking outside. And while we're doing this, I'm not just trying to traumatize you. We're doing the calming, breathing exercises, grounding, all these things to try to keep your physiological system inside your window of tolerance, even in exposure to the stressor. And then we might go up to like sitting on your front porch, and then taking a walk to your mailbox and back. And we're going to go a long ways before we're ready to go to Costco at 5 p.m. on a Friday. Okay, so that's maybe never that, but just too much, right? But we're going to go slowly. I just say that because it was a Costco lesson. I was like, whoa, this is a lot. And we're going to go gradual in exposure and weave in that regulation. So that's how exposure-based treatment works. is interesting. There are some treatments that had exposure built in that are now being studied where you take you maybe don't even need to do the exposure. You just address some of the things, what we call core beliefs, like the world is a dangerous place, or I'm not able to be safe. And you work on those and you can kind of shift those core beliefs. And then the response to the stressor goes down as well. So it's interesting. There's actually turning out to be maybe a lot of paths. And some people find that really frustrating because they want one answer. But as a therapist, I'm fine with lots of answers because I got lots of clients and they all have different lives and different needs and different backgrounds. And so if there's a lot of paths to recovery, I'm all for that. I'm not looking for the one right path. I'm just looking for the right path for you. Right. And we're going to do that together. So, so there's exposure-based treatments. There's now some work around maybe you don't need to do as much of the exposure if you do some of the other components. And then this is really important. Most people recover from a stressful event without needing treatment.
Mm-hmm.
So that means like the things we just do naturally work most of the time. You know, you've been through a stressful event, maybe you need some extra sleep. Maybe you need some time away. Maybe you need some time with family and friends. Maybe you need to go hang out with your dog for a couple hours and have a good dinner and get some sleep. And your sleep is a little disrupted and you feel a little on edge, but after 2 or 3 days, it starts to go away. That's normal recovery, happens most of the time. So what's important is just because someone's developed PTSD doesn't mean that those things aren't still helpful. They just need extra assistance. And that's what treatment is. It's playing, it's pulling on those natural mechanisms of recovery, but really turning them all the way up with the assistance of a therapist to help you find what those mechanisms of recovery are for you, and really do them. And that's sort of an interesting thing. So like exposure, people are like, oh, this is some, like your brain does it all the time. I mean, Caitlin, if you've ever been through like a really difficult situation, has your brain replayed it later in that day and the next day? And
Yeah.
your brain knows what it needs. It's doing exposure. That's what it's doing. It's kind of like, okay, let's replay this. And then over time, you're like, okay, the memory of this thing doesn't mean I need to panic and pull over the side of the road. I'm going to be okay. So your brain does exposure all the time. It's actually part of, I mean, we didn't create anything new in this field. We're just taking what your brain kind of already does on its own. And when it's stuck, help it get going again.
Yeah. I think that's interesting because I was thinking with some parts of with just anxiety or with trauma, kind of overthinking it and repeating the memories and that kind of making it feel more stressful. But then at the same time, it's like, well, I'm kind of processing it, I'm thinking about it, and it's like, yeah, it was bad, but I can like keep moving on with my life. So it's interesting how both of those can happen.
Yeah, that's so interesting. Yeah, and there's a lot on now we have the whole complications of social media and chronic exposure to stressors and all these other things. But, one of the things super interesting to me is what I think when we do exposure and treatment, for example, like we're going to recall the events and do these, like trying to, all these therapeutic techniques. What I see as a clinician is when we do that well here in like this contained space and environment, your brain doesn't need to do it everywhere else quite as much. And that makes it easier for you to go on about your life. So it's not about like, your brain's going to remember or not. Trust me, anyone who's experienced flashbacks or intrusive nightmares will tell you, your brain is going to recall the event. It's going to, or it's going to like, we call this avoidance. You're going to like avoid everything that could potentially remind you of the event. Well, that's a problem if now you can't leave your house because you're afraid of garden hoses, right? And so your brain is going to do exposure. What we think of in treatment, what we're doing is creating a space where we can do exposure in a controlled environment. And what I inevitably see is that your brain is like, okay, we got this. And it doesn't feel the need to replay it as much everywhere else in your life, while you're sleeping, while you're working. And when you recover without therapy, which is what most people do in most situations, most of the time, you kind of do it naturally on your own. So like when you tell your story about the terrible day of the car accident to your brother and your mom and your friend, and you do that, your brain is actually putting it all, sequencing it all out, doing its own narrative work. your reactivity to it decreases over time, and you're basically doing your own exposure-based treatment for yourself without the assistance of a therapist. So it's really a similar mechanism, we think. But yeah, your thing of like, well, but we don't want to think about it all the time. The brain also has a mechanism called avoidance, which is really trying not to think about it. And again, normalize, hey, you're trying to go to work, you're trying to take care of your kids, your brain's going to avoid thinking about the bad thing that happened. Yeah, that's adaptive. It's not a symptom. It's adaptive functioning. But if you have to do that all the time, it's hard to get on with your life, right? Especially if you start to avoid, leaving your house or being around other people. That's a very difficult way to live. But yeah, exposure, or replaying events, it's what your brain naturally does. And in treatment, we kind of leverage that in a really intentional way.
Yeah. Do you think that like talking about the traumatic event or trying to think about how you're feeling in this moment versus how you were feeling then, that is helpful?
Oh, yeah, such a good question. So we think about, so I'll rephrase your question a little bit.
Mhm.
What's the difference between exposure in therapy and just telling your best friend about what happened? Okay. Well, what I'd say is most of the time just telling your best friend about what happened is okay, is fine. And as part of your process of processing and recovery. But we all have it, I mean, I shouldn't say we all have. Everyone I've ever talked to has had experiences of recalling events that weren't helpful. Have you ever had the experience where like you had a really terrible day and then someone asks you about your terrible day and you tell them about your terrible day and now you feel more terrible than you felt beforehand? That would be my clue that avoidance was working for you in that moment. You should have stuck with it for a little bit longer. But seriously, what I would do as a therapist in that situation is I would pick up on the fact that you're actually reliving it
Mm.
because your heart is pounding. And then they did this, and then they did that, and can you believe that? What I would say right now is physiologically, your response and the memory they're right back together, and you're actually reliving the experience. And I don't think you want to relive good experiences, but terrible experiences, we don't really so much want to relive them. We want to remember them, but we don't want to relive them. And so what I would do as a therapist in that situation, and hopefully if I was your friend and you were telling me about it, and I was thinking like a therapist, I would slow you down and say, okay, let's go through this. And then when you're telling me the story the third time, we might just say, hey, let's just go for a walk. And so maybe that avoidance is actually pretty adaptive. So that's the difference between like good um good careful exposure and treatment and just reliving, because we've all experienced that where we just this happened, and there's no processing, there's no slowing it down, there's no co-regulation, there's no calming of my physiological state, and now I'm just really reliving it, and that's not helpful.
Yeah. Kind of just like puts you back in that same place you started.
You're just jumping back into the face to face with the rattlesnake again.
Mm.
And again, I don't want you to not be stressed around rattlesnakes. They're dangerous. So what I want you to do is not have to be, in constantly replaying that. It's just a natural process. And in most situations over time, people's reactivity to the memory decreases naturally over time. And in therapy, we're just really helping people when that process isn't working on its own, which is fine. That happens.
Yeah. It's very interesting, um, kind of how your brain is built to do all of these things to help you get through a situation, um, of like come out on the other side, but then also can kind of keep you stuck in that moment.
Yeah, I think, and maybe this is probably, I guess this is where it would be a good kind of thing to end with is, and this goes beyond traumatic stress to just like, this is just my theory on the mind and mental health in general, is I think almost everything that we call a mental health disorder or condition is one side of a coin, and the other side of that coin is adaptive. And that just it helps me with my work with clients in that um, what is happening in your mind and your body when you experience a mental health condition it started as an adaptive process, and then it got stuck, or it got turned up too high, or something happened and we got to unstick it, or, alter it a little bit. But at its core, it was adaptive, and we're not trying to get rid of it. And that's super easy for the alarm system. You got to have alarm systems. People swerve into your lane in traffic, basketballs come flying to your head, you got kids to protect. Like, you need an alarm system. So what about other conditions? It's a little bit harder, but I think it's still there too. Like, what purpose does depression serve? Well, actually, I think having the experience of sadness at times is fundamental to human experience.
Mhm.
Grief. I mean, I don't think you could have relationships, meaningful relationships with other human beings, if you didn't experience loss and grief at the end of those relationships. If you never experienced loss and grief, I don't think human relationships would work. I think there would be something big missing from our lives. There's a lot of work around folks who are very creative, often have periods of down and periods of activity, and those sorts of, and I'm not downplaying depression or bipolar disorder or any of these debilitating conditions that really can have a profound effect on our lives. But if we unwind to the core, that feeling of grief when you lose someone, or that feeling of sadness, or that just slowing down, that variability in human mood and experience is probably really, really important to who we are as human beings. We just know major depressive disorder, that process has been maybe derailed or has gotten stuck in some way. Anxiety, what purpose does anxiety serve? Lots. Without anxiety, I don't know if we'd be around. You got to be worried about dangerous things. And we know a little bit of worry is helpful. Too much worry is not helpful at all. There's some study, a little bit of stress helps you do better on a test. Too much stress, not good. No stress at all, and you don't study and you don't care, probably a problem too. So, and even in complicated conditions, I was challenged by this by one of our students. They said, "What's the purpose of psychosis?" I said, "Well, I don't know that psychosis has a purpose, but I do think that there's something about the human capacity for imagination and creativity that is probably the other side of that coin. I don't think plants experience psychosis. I don't. And I wouldn't wish psychosis on anyone, but there may be something about the amazing complexity and potential of the human brain that does make us vulnerable to that experience."
Yeah.
So I think I've yet to encounter a mental health problem or set of symptoms that doesn't have some core adaptive component at its core. And I think for that for me is super humanizing. It helps people ask for help. It helps people not experience shame and stigma when they experience a mental health condition. It helps people get the help that they need. And that's really important. And so that's what to tie it all back, that's what this roadmap model is really an attempt to do, is just to normalize and explain a process that can be very, very terrible and painful for people who experience post-traumatic stress disorder, but at its core was an adaptive process, and probably help them stay alive in a dangerous situation.
Yeah, absolutely.
Yeah.
Our brains are incredibly complex, and I don't know, it's interesting because we're still just a bunch of chemicals and neurons at the
It's
same
so
time.
complicated. It's so complicated, but it is an adaptive system
Yeah.
that helps us do all the things we need to do. And I think if we can approach mental health conditions that way, it just makes it a lot more accessible and available and humanistic, and helps people get the help that they need. So yeah.
Well, thank you both. Is this a good place to wrap up?
Yeah.
Yeah.
All right. Thank you both so much for having this conversation today and allowing people to listen in.